There are many causes of neck and back pain. Most non-traumatic causes of neck and back pain resolve within 4 to 8 weeks with conservative management. To evaluate the neck and back, the patient should describe the pain characteristics and features such as location, quality, radiation, and timing, including alleviating or exacerbating factors. Numbness, tingling, spasticity, or incontinence may indicate neurologic compromise. The neurologic exam is a crucial tandem exam in patients who complain of back pain. The spine consists of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. These vertebrae form 4 curves: cervical lordosis, thoracic kyphosis, lumbar lordosis, and sacrococcygeal kyphosis. Intervertebral discs provide cushioning, and several ligaments serve to stabilize the spine. Intervertebral discs between the vertebral bodies help to distribute weight across the vertebral body and also act as shock absorbers. Each vertebra has 2 superior and 2 inferior facet joints. The facets are located on the neural arch between the transverse and spinous processes. In this position, the facet joints allow lateral movement of the spine and prevent sliding of the vertebra. In the neck, the C1 and C2 vertebrae are unique. The C1 vertebra, the atlas, lacks a vertebral body and articulates with the skull. The dens of the C2 vertebra projects cranially through the C1 vertebra to form the atlantoaxial joint, which allows rotation of the skull.
The patient should disrobe above the waist. Evaluate the spine for normal curvature, including cervical lordosis, thoracic kyphosis, and lumbar lordosis. Look for abnormal deformity, malalignment, or rotation. You should also look for scoliosis or lateral curvature of the spine. Running your hand down the length of the spine with the spine slightly flexed may make abnormalities more obvious. Next, palpate the spinous processes from the C-spine downward to the L-spine. Tenderness may indicate compression fractures, malignancy, or infection. Finally, palpate the paravertebral muscles to evaluate for tightness, tenderness, swelling, or deformity. Next, test range of motion of the neck only. Ask the patient to gently flex their neck downward towards the chest. Normal neck flexion is about 45 to 80 degrees. In most cases, the chin should be able to touch the chest wall. Next, have the patient gently extend the neck. Normal neck extension is about 60 to 70 degrees. To test neck rotation, ask the patient to look over their shoulders. The patient's chin should be in line with their right or left shoulder. Normal rotation is about 70 to 90 degrees from midline. Lastly, test lateral flexion by asking the patient to try to touch their earlobe to their shoulder. Normal lateral flexion is about 30 to 45 degrees. If nerve root compression is suspected, further neurologic testing should be performed, including strength, reflexes, and sensation. Next, test range of motion of the thoracolumbar spine. To examine lumbar flexion, ask the patient to bend forward at the waist with their legs straight. Normal forward flexion is about 40 to 60 degrees. Ask the patient slowly to bend backwards, again keeping the legs straight. The examiner should stand behind the patient when testing extension in case the patient becomes unstable. Normal extension is 20 to 35 degrees. To assess lateral motion, ask the patient to slowly bend sideways. Normal spine flexion is 15 to 20 degrees. Discomfort with extension or lateral motion may indicate facet joint arthritis. Finally, the patient should be asked to rotate the thoracic spine with the pelvis fixed. The examiner may place their hands on the patient's hips to help stabilize the pelvis. Normal rotation is 50 to 70 degrees. If there is evidence of neurologic compromise, strength, sensation, and reflex testing should be performed.